Hi, my name is Gustavo Lopez. My topic is late outcomes of a randomized trial of high frequency oscillation in neonates. First, definition. Infants born extremely prematurely usually require respiratory support. High frequency oscillatory ventilation, HFOV, was proposed as a means of reducing the risk of bronchopulmonary dysplasia among neonates who receive ventilatory support. During HFOV, a constant pressure is applied to improve lung volume and oxygenation, while ventilation is achieved with the use of very low tidal volumes.
I'd like to take several minutes to demystify this device. This is a high-frequency oscillatory ventilator, as you know. This is the Sensormedics 3100A. And when initially confronted with this device in the ICU setting, many people are confused. Let me help. This is simple. This is the mean airway pressure, and you're familiar with that number from conventional ventilation. And this is the amplitude. This is the delta pressure, measured proximally in the ventilator circuit. These are really the only two numbers you need to concern yourself with. When we transition to high frequency, almost all patients are on 100% oxygen. We typically will pick a frequency based on the patient's size. In Samantha, a 13-month-old, roughly 8-kilogram child, we're going to pick a frequency of 10 hertz. And virtually all of our patients are managed with an I to E ratio of 1 to 2, giving a percent inspiratory time of 33%. So we're going to ignore these two numbers and focus on these two. So as you know, when we transition to high frequency, we will typically transition at a mean airway pressure 5 to 8 centimeters higher than we were on conventional. And one typically sets up the ventilator prior to transition. Now you can increase the mean airway pressure knob in one of two ways. You can adjust mean airway pressure by manipulating the size of the orifice on the expiratory limb, which is what I do when I manipulate this knob. So I'm increasing mean airway pressure and I'm decreasing mean airway pressure. And the other way to manipulate mean airway pressure is to increase the flow through the circuit, through that fixed orifice. And that's called the bias flow. And we can do that by manipulating this knob. All patients need to start with a bias flow of 20 liters per minute. Occasionally, when you've increased mean airway pressure maximally by closing the orifice, you will need to increase the bias flow to further increase the mean. So I'm going to now increase the bias flow from 20 to 25 to 30 liters per minute. And look what it's done to the mean airway pressure. It's increased it dramatically. Let me go back to 20 and you'll see that in reverse. 25 and 20. So that's mean airway pressure. Now the delta pressure is displayed here. It turns out we adjust the delta pressure by turning the power knob. So you actually increase power, and that generates a higher delta pressure, which is a measured variable. And we increase power simply by turning this knob. So I'm now aiming to increase the delta P to 60 by increasing power. The delta P is the peak to trough pressure, again measured proximally in the ventilator circuit. And to increase it further to 65, we simply increase power in another increment. So very simple device. The conventional ventilator is complicated. This is not. We focus on mean airway pressure and delta pressure. I hope that was helpful.
Application in medicine. In the studies, it was found that among school children who had been born extremely prematurely, those who had been supported by HFOV during the neonatal period had significantly elevated modestly better outcomes in tests of small airway function than those who had been supported by conventional ventilation.
I'm Dr. Margaret Lafferty, live from the 2017 Hot Topics in Neonatology Conference in Washington, D.C. We're here today with Dr. Erwin Rice, and we're going to be talking about his talk about high-frequency oscillation versus conventional mechanical ventilation in newborns with congenital diaphragmatic hernia. Welcome, Dr. Rice.
Yeah, welcome. Thank you.
Thank you for being here. Now, can you tell us, Dr. Rice, what was the main objective of your talk?
The main objective of the talk was the presentation of a trial we conduct in Europe in between the CDH Euro Consortium. And the aim was really to compare two ventilation modes in a very rare disease. And the challenge was that due to the fact that it's a rare disease, it's not easy to conduct such a trial. And yeah, that was the goal and the aim of this presentation.
That's great. And how did you design your study?
Yeah, it was a multi-center international trial with 9 centers in Europe, with high volume centers. So high volume centers means more than 10 babies per year in each center. And it was a trial where we indeed, as I mentioned before, compared conventional ventilation versus high frequency oscillation, and it was a blocked, randomized control trial, so a block randomization in each center.
That's great. Can you elaborate more about the randomization process and the groups that you had in the study?
These were babies with congenital diaphragmatic hernia with clear indications above 34 weeks of gestational age, no congenital anomalies, and informed consent antenatally, so that we were able to include the babies into the trial in between the first 2 hours of life.
And how about the major findings of your study?
Now, it was very interesting because the primary endpoint was death and or BPD at day 28. And we didn't find any difference in the primary outcome, but we found clinically significant difference in the secondary outcome, like pulmonary hypertension, like days on a ventilator, inotropic drugs, ECMO, and treatment failure. So that was very interesting. The limitation of this trial was we planned to do the trial with nearly 400 babies, but after 6 years we stopped after 171 babies. So that was the limitation of this trial. But nevertheless, it's the first trial worldwide on this disease in such a randomized control design.
Definitely.
Pros and cons. Pros. Extremely premature infants who receive HFOB fare better than those who receive it. The children who had been randomly assigned to HFOB also had superior outcomes in tests of large airway function counts. One meta-analysis of randomized trials concluded that the use of HFOB resulted in a significant but modest reduction in the risk of bronchopulmonary dysplasia, but a meta-analysis of patients' level data did not show any advantage of HFOB over conventional ventilation with respect to short-term outcomes, including bronchopulmonary dysplasia.
Have you ever wondered what happens when a baby takes their first breath? How do a newborn's lungs work? This story actually starts in the womb. Did you know that during this time, your baby's lungs are not used for breathing? While in the womb, your baby's lungs are filled with fluid and the blood vessels running through them are tight, making it harder for blood to flow through the lungs. In mum, these same blood vessels are relaxed, allowing blood to flow through. Oxygen is essential to life and is needed throughout our body to make energy. In mum's lungs, the blood picks up oxygen from the air. The blood then carries the oxygen from mum to the baby through the placenta. This provides the baby with the oxygen he needs, as the baby's lungs are not yet ready to do this job. When your baby is born and takes their first breath, the lungs open and the blood vessels going through the lungs widen. Blood flows through the lungs, making oxygen-rich blood for the baby. It can take up to 10 seconds for your baby to take their first breath, and it can take up to 10 minutes for that healthy baby colour to appear. Some babies can have difficulty with this change to breathing on their own in the outside world. When this happens, the blood vessels remain tight, making it difficult for blood to flow through the lungs. In this situation, the lungs are not able to generate the oxygen-rich blood needed. This is a condition which doctors call persistent pulmonary hypertension of the newborn. We don't always know why this happens, but there are a number of ways to treat it. Oxygen, given with the help of a ventilator, can provide the extra support needed for the baby to start breathing on their own. For some babies, oxygen may not be enough, and an additional treatment called nitric oxide may be needed. Nitric oxide works by relaxing those tight blood vessels in the lungs. This allows more blood to flow through and pick up oxygen from the air. However, 4 out of 10 babies don't fully respond to nitric oxide and need more help to get better. This is why research is needed to find additional ways to help treat these patients. Research is a very important part of improving the care of mothers and babies around the world. There are teams of doctors, nurses, research scientists and patients working hard to develop additional ways to help babies with persistent pulmonary hypertension of the newborn. To learn more about Irish research on maternal and newborn health, you can visit the HRB Mother and Baby Clinical Trial Network's website.
Issue applied in Ecuador. According to reports from United Nations, in Ecuador, 5.1% of all newborns are prematurely, for which high-frequency oscillatory ventilation HFOV will be a good option. However, the cost that this will have must be considered.
A respiratory distress syndrome is previously known as hyaline membrane disease and is a common cause of morbidity and mortality in premature babies. In this clinical video, we will see a newborn with respiratory distress syndrome and try to understand it better. With these words, I am Dr. Manish and I welcome you all to another interesting and crisp clinical video on respiratory distress syndrome. So let's start. One-hour-old male baby weighing 1.6 kilos presented with complaint of difficulty in breathing since birth. Preterm, appropriate for gestational age baby, delivered by lower segment caesarean section. Indication for lower segment caesarean section is labor dystocia. Baby cried immediately after birth. There is no history of meconium stained liquor. 25-year-old mother didn't take antenatal care. On examination, saturation is 78% to 80% in room air. Heart rate is 129 beats per minute. Subcostal retractions are present. Baby is grunting. Listen it again. Grunting is baby's attempt to maintain alveolar volume by prolonging and increasing expiratory pressures by breathing against a partially closed glottis. Based on presenting complaint and examination findings, a diagnosis of respiratory distress syndrome is made. To support the diagnosis, a chest X-ray is ordered. Chest X-ray is showing reticular granular opacification, air bronchograms. See, these are air bronchograms. And decreased lung volumes. This type of chest X-ray picture is consistent with respiratory distress syndrome. Finally, coming to treatment, which starts with maintaining adequate body temperature by placing the baby under warmer or in incubator. Warm, humidified, high-flow oxygen with nasal prongs started. Intravenous line secured for maintenance fluid, antibiotics, and other medications. Baby was subsequently intubated and surfactant in a dose of 150 mg per kilogram phospholipid instilled. Baby was extubated and put.
Conclusion. In a randomized trial involving children who had been born extremely prematurely, those who had undergone HFOB has compared with those who had received conventional ventilation, had superior lung function at 11 to 14 years of age, with no evidence of poor functional outcomes.
I am Dr. Kishore Kumar. I am Chairman and Senior Neonatologist at Cloud9 Hospital, Jayanagar, Bangalore. Jaundice can cause problems if it is not treated. If the levels of jaundice goes very high, then babies can get jaundice which can damage the brain. That is called kernicterus. Kernicterus is jaundice causing the pigment to deposit in certain parts of the brain, which can lead to babies developing deafness and also sometimes difficulty in looking up, called upward gaze, and also mental retardation. So this is a preventable cause which if you treat the baby with the high jaundice, baby should not have any of those problems.
Thanks.